Good evening, everyone, and thank you for joining us for Season 5, Episode 18 of Doc Talks with Dr. Forrest Tennant and friends. We have a really special show ahead of us this evening, and Dr. Tennant is really bringing us some great information about arachnoiditis and so much more than I could ever say. So I'll go ahead turn this over to you, Doc. I want to also please to remind everyone through our link tree, it's linktr.ee/doc talks, you will find a link that you can go straight to Dr. Tennant's website, and it's called Arachnoiditis Hope, where you will find so much information, invaluable information, bulletins, you name it, it's there. So please do take advantage of that invaluable resource. Thank you again. Thanks, Doc.
Thank you, Jimmy. Got an exciting program here for you tonight. You're going to give us a little update on some medicinals you have found helpful. We've got an interesting guest interview in a little bit. But we're going to start off tonight with something that's going to surprise you. And that is, we're going to talk in terms of intractable pain developments. You're going to hear something in about 5 minutes that you're going to wonder why you haven't heard about it. Okay? And that is, in this country, we have a certain kind of medical practice, and that the study, the treatment of severe chronic pain or severe intractable pain has been an afterthought. There's no big money in it, and nobody has really researched it, but there are some developments and some things that you should know. Now, adhesive arachnoiditis patients have about as bad a pain as you can get. Cervical arachnoiditis probably is the worst pain you can have. But RSD, CRPS, small fiber neuropathies, traumatic brain injuries, these are the major things. In fact, severe arthritis, at least some forms, are the big causes of severe intractable pain. And so I want to walk you through something here that's occurred in the last 2 decades. And you've never heard anything about this, I'm going to guess. Okay? Now, here's what I'm getting at. It's been now about, I would say, a little bit after, the turn of the century. It became quite obvious that something was obvious, and that was we had 2 kinds of chronic pain patients. We had those whose pain never went away. It was there 24/7. Unless they were asleep, it's there. And the ordinary chronic pain patient, however, would have a very mild form of pain. It would come and go. If it was there all the time, it was hardly noticeable. But we had this subgroup of people who had severe, constant pain. Now, frankly, they attracted me. They attracted me because they were, as my good friend Dr. Ibsen said, kind of refugees. And so we actually had a special clinic to research people who were in that category. Now, we asked the question, why did people come to our clinic and say, Doc, my pain used to kind of come and go. I'd have it 2 or 3 days a week, and now it's there every minute of the day. Unless I'm sleeping, it's there, and I can't stand it. I can't function. I can't think. I can't work. I'm out of it. Well, that's some of you out there know exactly what I'm talking about. Exactly what I'm talking about. Well, the first big discovery occurred. There was a woman biologist by the name of Watkins who was kind of famous for it, and some other people found out that in the human brain there's something called a glial cells, or mainly a microglial cell, and that the cause of the constant pain was that these special cells in the brain became dysfunctional. And even back 20 years ago, they thought the main reason they must become dysfunctional is autoimmunity. But they didn't know where the autoimmunity came from. Well, now we know today it's probably dormant viruses that reactivate. But back 15 years ago, they didn't know why. All they knew was these cells don't function. And therefore, we came up with some new terms that you're familiar with. One is central sensitization. All of you have heard that term. And what it means is that somehow or another, when you get this glial cell changes, the pain that you ought to feel is 3 times worse. In other words, if you stub your toe, it sort of hurts, but if you've got these glial cells that are dysfunctional, it really hurts. And so that's central sensitization. Unfortunately, a lot of doctors have used that term to deny people treatment, which is ludicrous. They ought to be giving them more treatment. Okay. Also, the term centralized pain came to be used. Now, the term central pain is an old one that referred to people who had pain due to a brain cancer, a stroke, or trauma to the brain. That was known as central pain. So this pain that causes centralization kind of became known as centralized pain. Well, it didn't make a whole lot of difference. But the point was, we had people who went from intermittent low levels of chronic pain to severe daily pain that didn't go away. And then we had not only biologic evidence of these cells that went haywire. Now, to complement this, they developed special brain scans to show these defunctive areas in the brain. And I can look at an ordinary MRI of the brain right now, and you can often see these spots in the brain that have become fibrotic and dysfunctional. So we can actually see a lot of this, and radiologists are even starting to report out some of these defective areas in brain tissue that cause the constant centralized pain. Well, what happened next? Well, let me tell you what happened next. We started having patients who not only complained about their pain, they complained about their pulse rates. Their pulse rates would go up to 140, 200, and they'd go into these paroxysms of pain, pulse rates going haywire, blood pressure going up sky high, and that hands would turn blue. And so we started to realize that there is a cardiovascular connection here to this central pain. Okay, centralized pain, glial cells that have gone bad, pulse rates of 160, blood pressure of 180 over 120, and blue hands. That's called Raynaud's phenomenon. Okay, and then as time went on, we realized one thing, and I want everybody who watches this to do one thing right now. If you haven't lately, feel your hands and your feet. I'll bet they're cold. In fact, we found out that one of the simple ways you determine whether you have centralized your pain is your hands and feet are always cold. Okay? And you've got a couple of other things. Well, this went on to lead to the discovery that I want to talk about. And this led to the discovery of something called descending pain. Now, maybe some of you have heard that term, but if you've got adhesive arachnoiditis, if you've got RSD or CRPS, if you've got pudendal neuropathy, if you've got constant pain, listen up, because you didn't know it, but you have something called descending pain. Now, let's talk about this for just a moment. Everybody who's a severe chronic pain patient needs to know the terminology of the day. The physicians and the medical profession, as a result of this scenario, has adopted some standard terms of pain that you need to know about. Okay? Now, they like to use the term nociceptive, which means pressure pain, but that's officially known as ascending pain. Ascending, okay? Ascending. Now, what does ascending mean? I hope you can maybe see this, okay? Now, what this shows, hopefully you can see it, this is the nervous system with nerves all over the place. And ascending pain means that you've got an injury down here in your foot or in your cauda equina or your neck, and it's going to go into the spinal cord and go up to the brain. That signal is composed of a form of bioelectricity that we don't understand very well, but that's called a pain signal. So pain is really some form of bioelectric energy, that carries, we actually think it's matter, that's carried by these nerves up to the brain. Now that's ascending pain. That's ascending pain. Now, you don't hear many doctors talk about ascending pain. They will talk about nociceptive pain, but ascending is actually a better term because it says what's going on. Now, ascending pain is the one that's been traditionally treated. How do you treat ascending pain? Well, that's opioids treat that, okay? And a few other drugs like ketamine do and naltrexone does. But opioids is the major blocker, if you will, treater of ascending pain because that ascending pain interacts with something called the opioid receptor and the endorphins. And so ascending pain is controlled primarily by opioids, okay? Opioids, and maybe a few other drugs, but that's the main one. That's ascending pain. Now, as time went on, and you will now hear this term, and I'm a little surprised that the medical profession has adopted it, but they have adopted the second kind of pain, and that's called neuropathic pain. Neuropathic pain. Now, what does neuropathic pain mean? That means that in these nerves, whether the nerve is up in your leg or your spinal cord or brain itself, if there is a defect or a dysfunction in the nerve, it's going to block or back up this bioelectricity, and that's painful, okay? Now, how is that treated? Well, that's been the rage. In fact, I think it's over-raging, okay? Now, the age-old treatment for that were drugs like mefrabamate and the benzodiazepines, Valium, Xanax. Now today, the big rage is gabapentin, baclofen, then pregabalin, which is Lyrica, okay? Now these drugs, what they do, they interact with something called the gamma aminobutyric acid receptor. You don't need to know that, but it is abbreviated GABA. And so the doctors today love to use baclofen. They love to give you Lyrica. They love to give you gabapentin. Now, they just hate to give you something that works like Valium or Soma, okay? But what they're giving you is a drug to try to make that bioelectricity pass the blockage, the dysfunction of the nerve, okay? Now, if you've got a disease like adhesive arachnoiditis or even non-adhesive arachnoiditis or CRPS, you've got a lot of blockage. You've got a lot of dysfunction in those nerves. And so that's why you're given this. Now, one of the things that just drives me nuts, I find a patient who's not only taking baclofen, but also Lyrica, gabapentin, Zymbalta. They're taking 3 or 4, and every time the patient goes in to see the doctor and says, you know, doc, my pain's not getting any better, they give him one more neuropathic drug, okay? And so you find all these people taking 2,000 milligrams of gabapentin, walking around like zombies. They're given Lyrica, which is breaking their insurance policy. But anyway, that's where we're at today. Okay, so the medical profession is treating pain almost exclusively in this country for ascending pain and neuropathic pain. And anything that you look at, that's what they're giving. That includes implanted stimulators, that includes intrathecal pumps, this includes almost all of the pharmaceuticals. Now, researchers came along and found out that there is something known, and the proper name is descending pain. Descending pain. Now, I hope that some of you have at least heard that term, because if you don't understand descending pain and you don't treat it, your pain's not going to be very well controlled. Now, what is descending pain? Descending pain comes out of the brain when those glial cells get dysfunctional, it cannot absorb or digest all the bioelectric pain signals. So what does it do? Send them back down the spinal cord. Send them back down the vagus nerve. And so the bioelectricity is being sent back down the autonomic nervous system, and it's extremely painful. Okay? So the catch to this is that opioids don't help it. The catch is neuropathic pain medications don't help this. It requires a special set of medications, and there are several of them. And I'm going to go over what they are, how they work, but in the vagus nerve, in the spinal cord that goes downward, descending, there is a receptor called the adrenergic receptor, or technically the noradrenergic receptor. And that receptor has the ability to block the pain if it's activated. Okay? And so everybody who's got constant pain, if you want pain relief, and you want to quit going into your doctor asking for more and more opioids or more and more Valium, you're going to have to treat your descending pain. Okay? Now, how do you treat the descending pain? Well, there are three classes of things you can do. Number one, you can take what's called a blocking agent. Now, there are two that work on descending pain. One is one of the old muscle relaxants called tizanidine. And the doctors don't mind prescribing that. It's nice and safe, and it's a pretty good blocker, and it gives a lot of pain relief to some people. But that's a muscle relaxant, and it's called tizanidine. The other agent, which is totally underused, is something called clonidine. Okay? It was an old blood pressure medicine, but it specifically blocks those noradrenergic receptors in the descending pathways. So those are blocking agents, tizanidine and clonidine. Now you have a group of agents that will stimulate the noradrenergic receptor to block out the pain signal. Now I'm going to tell you what those are. And the doctors don't like to prescribe a lot of them, okay, because they come under the class of stimulants and they don't like that. But let me give you the ones that are being used. And I'm going to read you the list here, and then I'm going to come back in a second and say a little bit on how they can safely be used and about dosages. Plain old dextroamphetamine is one of them. Plain old methylphenidate or Ritalin is one of them. Your amphetamine salt, that's kind of new, that's Adderall. One of the old weight control drugs, phentermine, is in that class. Okay? So you've got these 4 or 5 stimulant type drugs that are used for ADHD and are used for depression, but you need them for descending pain. Okay? Now, you don't need much. They work a little different than opioids. They've got a real ceiling effect. In other words, a dose of 10 milligrams of Ritalin a day might be all you need. Maybe 5 milligrams of dextroamphetamine. Amphetamine salts, the lowest dose is 5 milligrams. Now, you may need more, but one of those works very well to block out the descending pain and keep you from having to take more and more opioids or more and more gabapentin. Okay? Now, getting your doctor to prescribe these things may be a good trick. They're afraid of these drugs, and they never heard of descending pain. So you've got a real job ahead of you to try to get these drugs that you need. Now, if you can't get them, there are some herbal products that work pretty good. They're not as good, but they don't work too bad. I'm going to give you a list of those. You got a pencil? Write these down. All right, the first one is a mushroom derivative known as lion's mane. I know it's kind of funny. I don't know why they call a mushroom lion, but nevertheless, lion's mane is a mushroom, and the extract of that works pretty good. Ginseng. Ginseng has a lot of stimulant activity. The third one is Mucuna. It's spelled Mucuna. And another one that's had a little publicity in recent years, St. John's wort. Okay? Now, those 4 herbals, you're going to need to double or triple probably what's on the label. They get you pretty darn good control of descending pain. Okay? Yeah. Now, I'm going to talk to you about another set of studies that you're going to hear more and more about from me. And that is these conditions like adhesive arachnoiditis or cervical arachnoiditis or CRPS, they do something else which everybody needs to know about, and that they suppress hormone and neurotransmitter production. Actually, they don't suppress them, they use them up. The pain and the disability and the suffering, even the depression, is so great, they use up your daily normal supply of noradrenaline, your normal daily supply of cortisone or of progesterone or of DHEA. And for good recovery and pain relief, you need to replenish those hormones. Testosterone in particular, in both men and women for some reason, is very highly connected to pain relief. So what happens, and there are studies on this, shocking, that people reduce their normal norepinephrine, and so some people can get some pretty good pain relief by taking what's called the precursors of norepinephrine or noradrenaline, and they are 2. One is phenylalanine, and the other is tyrosine. Okay, and you can get cheap old tyrosine or cheap old phenylalanine at the health food store, and taking 500 or 1,000 milligrams a day might just help your pain out. That's a little stretch for some people, doesn't work for everybody. But let me go over it again. To control descending pain, you've got 3 classes of compounds. You've got the blockers, the tizanidine and the clonidine. Most doctors will prescribe one of those. Then you've got the direct activators of the noradrenaline receptor, and they're drugs like Ritalin, Adderall, dextroamphetamine, phetamine. And then you've got the precursors of noradrenaline, phenylalanine or tyrosine, and you can take those, and that may help you, because the studies are really pretty clear, and I've done some myself, that people who have really severe pain, you can take their adrenaline levels and noradrenaline levels, and they're low. They've gone too low, and you have to, no wonder they're in pain. Anyway, that's where we're at on this. I highly encourage everybody. I'll wrap this up. When you communicate with your medical practitioner, I want you to understand the 3 classes of pain relief, drugs, and pharmaceutical approaches today. One is ascending pain, second one is neuropathic pain, and third is descending pain. And if you've got severe daily constant pain, you're going to need to tackle all 3 types. Now, let me warn you, when you go to your pain clinic and you go to your doctor, let them know that you heard this and you're inquiring about it, because they probably don't have a clue. Okay? Modern medicine has pretty well denied the whole concept of pain centralization, glial cell dysfunction, autoimmunity of the brain, descending pain, because there's no money in it. Okay, there's no heroes over this, but that's what you need for some relief. And but it's good that you know the scientific basis of where we're at on this. And I'll just wrap this up. I get letters, I get communications daily. People can't get enough pain relief. They think all they've got to do is go get more opioids. Guess what? If all you're taking are drugs for ascending pain like opioids and neuropathic pains like gabapentin, and you're not treating your descending pain, pretty soon you're going to find your opioids and your neuropathic agents don't work very well. Somehow or another, you've got to balance all 3 to keep all 3 working. Okay? So that's what I want to close with. You treat all 3 components if you have it. Anyway, Jamie, you told me earlier that I know you're out there talking to a lot of people and scouting, and this program is vitally interested in anything anybody can do to help themselves, and we're particularly interested in any natural or herbal products that a person can buy, because health treatment is certainly the name of the game for a lot of our viewers. Jamie, take it away. You've got a couple of things you want to tell us about.
Yes, sir. Thank you so very much. I did want to let people know that there are some brands that I have found particularly helpful, and I was surprised. This is for informational purposes only, of course, not intended to diagnose, treat, or prevent any illnesses. But this is by a brand called Horbach. And I was surprised at the potency because the price was so low. Usually you get what you pay for, but this is called Adrenal Glandular, and that's by Horbach, and it's 350 milligrams of adrenal glandular tissue, and it's bovine. I find that if I take one, I take my day off, I take the Sunday off, and then I take one each day, and it really has helped with the adrenal fatigue. Another one I wanted to tell you all about that Dr. Tennant recommends, but it's a very inexpensive one. It's by Source Naturals. I don't sell these products. These are simply things I have found that have helped me. If you are in a situation that you may need to wean from a GABA agent, or if you and your doctor have agreed that that's what you'd like to do, this may help, as it does contain GABA, which is the gamma aminobutyric acid, and it's 125 milligrams, and it contains glycine, 50 milligrams. It contains 25 milligrams of tyrosine, which Doc just mentioned, and then also 20 milligrams of taurine. And so those actually, it's really neat how it the synergistic effects, because it explains that the GABA and the glycine and the acetyltyrosine is a precursor to the neurotransmitters dopamine and neuroepinephrine, as Doc has taught us. And in addition, taurine supports the calming effects of GABA. And so this is a lozenge that just dissolves under the tongue. I was always under the impression that taurine was something that was a stimulating supplement. So I was surprised to see that those two work synergistically together. Two more, and I'll be finished. One that I have found that has kept my viral load down is between the astragalus and andreographis. I said that wrong, I think, but they're both by Earthborn Elements, another very reasonably priced. This has 200 capsules in one container. So that is where I got those. And then the other ones I found on sale was in a 3-pack. And a lot of us have to wait until things are on sale before we can do this, but it was in a 3-pack. That's how we are able to do our giveaways of supplements. And this is the PEA with luteolin and turmeric, and it is made by Ross Mallow. It does contain 1,500 milligrams of the PEA, palmitoyl ethanolamide, and then it has 300 milligrams of luteolin, and then the turmeric root extract is 200 milligrams. So these have helped me. I can tell when I do not take them. I didn't realize how much it was helping. So I hope that helps you all. It's been great for me. I know not everything works for everyone, including pharmaceuticals, but it's always worth a try. So thank you.
Jamie, all 4 of those products are dynamite and are highly recommended. Let me make a couple of comments on astragalus for a moment. There are some studies done in the laboratory as to what of these herbal agents will keep the Epstein-Barr virus from reactivating. Astragalus is one of those. Luteolin is another. And I've now, among my 3 top herbal recommendations are either quercetin, serrapeptase, or astragalus. Okay, that is really great. Something else just flew up on the screen, and I apologize. I left out an agent that on your descending pain, and that's Bioelectricity or Provigil. And the doctors don't mind prescribing that. It's good and safe. It works very well. I do like that drug. Sometimes it's a little expensive, so the insurance companies may not cover it. Modafinil is on the list. I should have mentioned it. Okay. Thank you so much. And we're going to go on now. Do we have our guest with us?
I believe we have Kris with us.
Good evening.
We are. Good evening, Kris. It's so good to
Hi,
see
Kris.
you.
Hello, my dear friend.
Hi, Kris. How are you doing?
Hi, I'm just doing well, thanks to you.
Well, you're welcome about that. Kris, let me give a little background about you for a minute, and then we'll let you give them the facts. I'll give them some falsehoods here. First off, I'm so glad you're on the program. You're one of our unfortunate friends with adhesive arachnoiditis, but you're also an RN and had a good career before you got this disease. And there's nothing I like to know what I like to interview more than doctors and nurses who have the disease, because you've got the facts, okay? And so let me start off before we get to your disease. First off, where do you live now and where do you come from? And tell us a little about your past career.
Well, in a nutshell, I live in the beautiful Southwest in New Mexico, and I've been here most all of my adult life. And prior to arachnoiditis, and even while with arachnoiditis, I practiced for a while, and the last thing I did was started a stroke program at a local hospital where I worked. But I've done everything from hospice to cardiovascular, cath lab. Probably the bulk of my career has been in cardiology, I would say. But I've loved it all. I can't say I'd want to go back, but here we are.
There you go. Kris, how did you get adhesive arachnoiditis?
Well, I'm gonna try to be real concise here.
Wait.
I believe that it was from multiple epidural steroid injections, repeated injuries to my back, doing things that I thought I was graceful, and I truly have never been, and have hurt my back over the years. And so, yeah, so I've had a lot of epidural steroid injections, and even had one procedure where the pain management doctor said he needed to go in and scrape out all of the epidural adhesions after one of my surgeries, which, I mean, just repeated insult after repeated insult to my back. Several surgeries, some bad procedures, and then the discovery of Ehlers-Danlos syndrome, which I tried to ignore and deny. But all of your bulletins, and I used to say, oh, okay, well, I don't have that, I don't have to worry. But I just want to extend out a reminder to everyone that Dr. Tennant, I believe you said that in your practice, and you've seen more people with arachnoiditis than anyone in the world, I dare say, and 80% of us probably have Ehlers-Danlos syndrome. Does that sound consistent with what you thought, doctor?
Well, let me put it this way. You have, let's put it in a perspective. You had these epidurals, you had back surgery, you end up with adhesive arachnoiditis. We have thousands of people who have epidurals and surgery and come out very good. So some of you ended up on the short end of the stick. And I believe, I hate to say this, and it's probably a long time in coming. I believe before anybody has an epidural or a spinal tap or a surgery, really should be screened for Ehlers-Danlos and other connective tissue diseases, because you're just simply not going to heal. Okay. And so,
True.
what can I say?
You're very ahead of your time in that thinking. And if we could just get everyone to understand adhesive arachnoiditis, I'd be happy. But anyway, yeah, you're right about that.
Yep. Now, how many epidurals or surgeries did you have? Have you got a number to it?
You know, I lost track because they always do those ESIs in groups of 3, right? And we ended up we were truly treating adhesive arachnoiditis with more epidural steroid injections because people don't know how to diagnose and treat arachnoiditis, nor to call it, of course, on the radiographs, right? So I've had two invasive surgeries. One was a fusion, the other one was a decompression. So it encompasses the lumbar and the sacral area. So I've got cauda equina issues along with the lumbar. So two invasive surgeries, and oh my gosh, just too numerous to count on the ESIs. I mean, it's got to be greater than 15 or 20.
Yeah. I have another question and a point I would like to emphasize, see if you can help us on. Could you give us a date in the past, approximately, what year you may have had your first ESI?
Yes, I thought about that before we're meeting tonight. And I figured that was around 2010.
2010.
Mm.
Now, let me ask you another question that I already know the answer to. Did you have an option?
I really wasn't given any options. In fact, they even used that kind of as a weapon to getting my pain medication. I'm sure many of us have been through that, but that's another story altogether.
Well, the 2010, the whole, since the mid 90s, I go back, we were doing better pain treatment for people for intractable pain in 1995 than we're doing in 2025. And the reason is that we had to do the basics. Now, since 1995, we have long-acting opioids, we have intrathecal pumps, we have epidural injections, we have implanted stimulators, and have we really advanced? Have we really gone further? I mean, one really has to take one look at this technology, and I'm biased because I often think of myself as being on the mop-up crew.
Yes, you are.
Yeah.
And we always have to follow the money, and that's the bottom line.
Yeah, well, they are. But what I feel sorry about, and make a point, is that those of you who didn't have access to alternative treatments other than ESIs, and who didn't have any access to arachnoiditis treatment. I mean, even I didn't have any good protocol up until, let's say, 5 years ago. And so I know a lot of people who are watching this who are disabled, bedbound, in severe pain, and had to go, and you're one of them, because you really didn't have any options. I'm not sure I would have had an option for you at that time, because these are unintended consequences of high tech. Okay? Yeah. Fundamentally, if you want to look at it that way.
Yes.
Yeah.
Yes, but I met you, I think it was probably 8 years ago. And it was Dr. Guess who I met you through. He was my treating provider at that time. If he's on the call, I'd love to say hello to him. But you also came on board and gave your recommendations, and I've followed your protocols faithfully ever since, and they have given me a quality of life I know that I never could have had without them. And frankly, I don't think I would be alive today if it weren't for these treatments, because I was at a dark night of my soul at one point where I couldn't even imagine the amount of pain that I was in. And you just pray that God will take you because you have no options. And, you know, if somebody, if he hadn't intervened, I wouldn't be here because I couldn't have lived like that. So knowing that, Dr. Tennant, I just have to give you my heartfelt thanks. And I believe in what you teach, and I believe in the protocols that you have. And the good thing about it is, if we can't do one piece of it, you have alternatives for people.
Yeah.
And that's important. Never say I'm at the end of my road, guys, because there's always another avenue to take. We think outside the box. We never say no. We go in the back door. That's how I got to Dr. Tennant. I thought, well, I'm never going to get in to see this guy. I better go see Dr. Gez. And so, you know, there's ways to get around everything. Don't give up.
You bet. Now, let me ask you a question. How many times have you thought about suicide?
Seriously, just that one time, Dr. Tennant. But I've thought about it more times than I can count.
Yeah. What would pull you out of it when you did get that thought?
My children.
Your children, uh-huh.
And my God.
Uh-huh. Yeah. Has your family been supportive of you?
Yes, they really have.
Uh-huh.
Yeah.
Let me just ask you this. Both as a nurse and somebody with this disease, give us your laundry list. What do you want to tell somebody who's both newly diagnosed or old timers like you?
Yep.
Give us your best shot.
Oh, I'd be happy to. And I kind of just went into that now, and when I'm really espousing going for it. This is your job in life now. Your job in life is to find out as much as you can about this disease. Everything you ever want to know, and then some, is on Dr. Tennant's Arachnoiditis Hope site. There's always hope. There's always another step you can take. There has been for me. And it takes a little work, but what's the alternative? There are options out there. And just to know, I mean, I'm not going to go into this because I don't believe that it's appropriate, but faith really helps.
Absolutely. Yeah.
Yeah.
Yeah. Yeah. I think if you have adhesive arachnoiditis or one of these other conditions, you want to stop at the church on the way to the doctor's office. You might be better off.
Yes.
They tend to work together.
Exactly.
Yeah.
Exactly.
Yeah, no question about that. What's your? Now let me ask you this: you've managed to survive. What are your plans now, both for quality of life? How long do you want to live? Where do you want to go from here?
Doctor, I didn't think I'd be alive at this point for this long, quite honestly. As reflected by my dwindling financial prospects. Anyway, I am currently studying for my CPC designation as a certified professional coder. So I'm working on a medical coding certificate. I'm able to do this in my recliner because I can get out of pain almost in a certain position. So if I can lay back a little bit, I can decompress enough back there to where I can get down to maybe a 4. So I can work there. That's like heaven, right? A floor. So that, as well as some other adaptive equipment that I have, just a simple desk that a neighbor made for me. Yeah, so there's that. Everything can be done online. It's going to take a while. It's going to take a while to get all that put together because it does take a little longer for us. But what else am I going to do? I need some stimulation in my brain.
Yeah, absolutely. To close out here, let's just talk about your medications and exercises. what do you have any real thoughts on best medicines, best exercises, uh, either natural medicines, prescription? Give us any of your thoughts along those lines.
Sure. My latest thing is with my friend Katja, who's on the call today, is that we do yoga together, but not together. We do it, she does it at her house at 10 o'clock, and I do it at mine at 10, and we connect online and say, "You ready to go?" And so we do really modified restorative yoga. And you can find YouTube videos on that. And I really modify. I mean, I can't do nearly half of what they're doing, but I try. So there's that.
Give us a demonstration. What exercise?
Oh no, no, never, doctor. Never could do that. No one, it's for no eyes. It helps. I come out of there feeling very good, physically and mentally.
Yeah, well, yoga stretches, and that's what I like. Yeah, no, yoga has my blessings. That's for sure.
Thank you. I also appreciate rocking. That really helps when things get bad. Staying hydrated is so important. We just underestimate that. It can make the difference in your day. Yeah, those are my pearls at the moment.
You mentioned hydration. You're absolutely right. You got a rule you like to follow?
Yes, my dear children gave me this big jug. I don't know if you can see it, but I fill this up 2.5 times a day. And I think this is about, I don't know, 70 ounces. So I'm drinking quite a bit, and I have to use some flavoring with monk fruit. That's kind of the least harmful artificial sweetener out there. Monk fruit is pretty good. So a couple drops of something with that, and it makes it more palatable to get down. And
Do you
just
drink
carry a jug with you.
every 2 hours? Do you have a time frame you like to drink on?
I don't, doctor. I just make sure that I've always got that jug in my view, and it's always nearby. And every time I think of it, I just take a drink. And if the half of the day is gone and I'm not done with one jug, I tell myself to speed it up, and I fill it up again.
Does your pain get worse if you don't drink?
Oh, yes. Thank you for mentioning that, because I have noticed that trend, and that's a good reason, to do it. One of the main reasons that I do it.
Now, I don't know that you know, do you know that there's a good biologic reason why you get pain and why you got to drink? I'm going to give it to you. Okay. It has to do with spinal fluid. Okay. Now,
Yes.
the spinal fluid is absolutely a critical part of dealing with AA. Now, the body makes about 500 milliliters of spinal fluid a day. It turns over every 4 to 6 hours, believe it or not. Now, what does spinal fluid do? Spinal fluid, first off, lubricates the cauda-equina nerves, and if you don't get lubrication, it's painful. Those nerves rub together, okay? Secondly, the spinal fluid brings all your nutrients and medications. In other words, if you got a fentanyl patch on, you don't have enough spinal fluid, you might as well not have put on the patch, okay? In other words, all those supplements. Now, and what happens is that if you don't drink enough, you got to have a full tank. And people don't realize that the spinal fluid is a fluid independent of all other fluids in the body. It's in a closed compartment. You need a new turnover every 4 to 6 hours. And if you don't drink enough fluid, and that drops down, it's like not having enough gas in your gas tank. You are going to have pain, and you're going to have weakness, and you're going to wonder why you're dizzy and why you're depressed. In other words, drink up.
Yes, yes.
And incidentally, with what you got, if you put a little alcohol in there, it doesn't bother me either.
I'm afraid to start. I'd never stop probably, so I just
Yeah,
don't.
you and me both. Yeah.
Yeah, yeah.
But anyway, that's why why drinking. In my new little handbook that I'm doing, I say at least every 2 hours, drink something.
Yes.
Yeah, drink.
Yes.
Well, that's a great lesson for today, and very unappreciated. But you said you also that you rock. What do you do to rock? You rock on your feet? You got a rocking chair? What do you do?
I do. I rock. My recliner also rocks. So I sit in there and purposefully do it at least once a day to get the cerebrospinal fluid moving. Because
Yep.
as you said, it removes the toxins and circulates them so that they can be dispersed and, absorbed by the body. And if you're not moving, it's sitting right there on the cauda equina. It's going to hurt.
Yeah, absolutely. Uh-huh.
Yeah.
Yeah. Do you find yourself thirsty, or do you drink now pretty much just out of habit?
I think the clonidine makes me drink a lot, my dry mouth with the clonidine. And it's a habit now, and that's a good thing.
Yeah. Now you do take clonidine?
I do.
Uh-huh. Yeah. And how much does the clonidine contribute to your pain relief? 10%, 20, 30? What do you think?
I would say 25%.
25. That's probably a good, that's about what you expect by controlling descending pain. Yeah.
Yes, doctor, and I wonder too, because my heart rate, I mean, you described me and so many of us, my heart rate goes up to greater than 140, and that can't be from the sinoatrial node. That's getting a little scary, and my blood pressure gets up there too. And the clonidine helps keep both of those in check.
You got it. Yeah, absolutely. Kris, as always, it's been a pleasure. You've been very educational. I think your message will carry to a lot of people. We'll be in touch. Thank you so terribly much.
Thank you, doctor.
You betcha. And Jamie, we're going to sign off here tonight. And Kris, you couldn't have been a better example today, but I just want everybody to leave here. If you've got constant pain, you've got three different kinds. You've got ascending pain, you've got neuropathic pain, and you've got descending pain. You got to take care of yourself, but also, would you do me a favor? Educate all those medical people out there also. With that, thank you, everybody. We'll see you next week. Good night.
Good night. Thank you, Dr. Tennant. Thank you all so much for being here with us. I hope you all have a great night tonight. And you're welcome to unmute your mics if you want to say good night to everyone. And we'll see you next week. God bless you. You're not alone. And I love all of you.
Good night,
everyone.
I love you.
Good night,
Love you
everyone.
all.
Thank you, Kris.
Thank
you, Kris. That was beautiful.
Added
So
to your
helpful.
Night.
will help the
Good night,
absorption.
everybody. God
Night.
save the pain warriors.
Mhm.
God bless you.
Good night, Valerie. Good night, Jamie.
Good night,
Good night,
Carson.
birthday buddy.
Good night, Jamie. Good night,
Good
everyone.
night, Valerie.
Night.
You're all
Good
such
night.
precious, precious souls.
I love
Please
you,
hold
Jamie
on with us.
Love
Sanchez.
you, Jamie.
I love
Keep
you
going.
all.
God loves you, and I love
Aw,
you.
I love
God
all
loves
of
you, and
y'all.
I
Love
love
everyone.
you too. All of you. Yes, every one of you. We'll
Yep.
see you next week.
And I love you
And
Thanks,
too,
I will
Ashley.
be,
Jamie.
yes, we love all of you all. I'm working really hard to get caught up. And I think this was one of the best shows we've ever had. That's just my opinion. But I've really learned a lot tonight. And Kris, Dr. Tennant, I'm over the moon with all this information. It's incredible. Thank you all again. Good night.
That's how
Hold
I
on
got my
tonight.
Night.
Jamie.
Thank
It's
you.
the Harbox brand. It's a lot cheaper, and then I get 250 capsules.
I'm telling
of
you,
NAC and 15 cystine.
unbelievable how potent they
Jamie.
were. I was very surprised by the potency because I mean,
Yeah.
I don't think I paid more than $15 for this, if I remember correctly. That's
I
not
think mine
very
was like
expensive.
25, and
Was it?
it's 1,200 milligrams, but I'm only taking a 600 milligrams, so I just only take one tablet.
There you go.
And you think about that, that's enough to last you a whole year.